Chapter 13, Hemoglobinopathies with Qualitative Defects. When we look at the globin portion of the hemoglobin molecules and we talk about hemoglobinopathies, these are things that are genetically determined by the abnormality of the structure or synthesis of the hemoglobin molecule. The abnormality is within the globin chains. As a qualitative measure, this is a structural defect. As a quantitative problem, these are defects in globin synthesis. Qualitative defects are genetic mutations in the coding regions of a globin chain. These results in an amino acid deletion or substitution in the globin chain, which causes a structural variation in one of the globin chains. The clinical expression depends on the class of the globin chain involved, either alpha, beta, gamma, or delta, and it would depend on the severity of hemolysis. We have a compensatory production of other globin chains in certain types of conditions. There are over 1,100 abnormal hemoglobins, and due to genetics and phenotype expression, it has to be determined which loci of the chains are affected. Most of these mutations are seen in the beta chain. The beta chains are a single copy of each chromosome on 11, associated with clinical phenotype when it's mutated. The beta globin chain is a component of hemoglobin A, which is the major adult hemoglobin. As for the alpha gene, we see here that it's duplicated on each of the number 16 chromosomes. Mutation of a single gene locus leads to a small amount of abnormal hemoglobin due to the ability for compensation, and it's less likely here to cause any clinical complications. Most of these variants come from a single amino acid substitution or deletion in globin polypeptide chains. And here, clinical symptoms are variable with no abnormalities, or they can be expressed when the hemoglobin is altered due to its function, stability, solubility, and also its oxygen affinity. Now first, you're going to be able to identify the anemia using a CBC. The RDW and RBC indices distinguish between a hemoglobinopathy and a thalassemia. It will also help you determine certain kinds of variants, and we need to be able to quantify this based on electrophoresis. So here you have an image of an electrophoresis pattern. The top part is what it would show as a control to ensure that the gel is working. The bottom would be an example of a patient, and you can see the portions of thicker lines where the hemoglobins that are present are available. In the middle portion, you're starting to see abnormal thickening of the chains of S, C, and F, which happen in the complicated hemoglobinopathies we will be discussing soon. The standard nomenclature for hemoglobinopathies really depends on the designation of the problem. Is it a mutated globin chain, a position of the affected amino acid that is a problem? Is it a helical position of the mutation, or simply just an amino acid substitution? The disease or anemia would be classified as either homozygous, which is both genes that code for a structural globin variant, or as heterozygous as a trait, where one gene codes for a normal chain and the other one is the structural variant. Symptoms occur when amino acid substitutions at critical sites within the molecule affect the solubility, oxygen affinity, and stability of the hemoglobin molecule. These altered solubility affects when these nonpolar amino acids are substituted for a polar residue near the molecule's surface, and examples of this are hemoglobin S and hemoglobin C. Sickle cell anemia is the most common symptomatic hemoglobinopathy. It's prevalent in Africa and the Mediterranean Middle East and Nepal and India. Some geographical areas of migration, such as North, Central, and South America, have also seen a lot of these hemoglobinopathy cases. Hemoglobin S is a nonpolar valine substituted for polar glutamic acid. Hemoglobin S occurs when there's a nonpolar valine substituted for a polar glutamic acid at the 6th position in the alpha 3 helix of the beta chain, which is described below. The beta chain, 6th position in the alpha 3 helix, where valine is substituted for glutamic acid. The substitution on the surface of the molecule produces a net decrease in negative charge, which leads to several complications. Hemoglobin S is remarkable because the solubility in the deoxygenated state is markedly decreased, where there is polymerization of these molecules that form rigid aggregates called drepanocytes or sickle cells. Reversible if they are oxygenated, but over time, this polymerization leads to a permanent distortion, which leads to a hypotoxic, acidotic, hypertonic environment within the spleen, kidney, and the bone marrow. Also promotes the sickling ability. Now, this really depends on the proportions of hemoglobin A, S, F, and A2. The non-S hemoglobins interfere with polymerization, which the total hemoglobin concentration seems to be increased as shown in the MCHC. Repeated cycles of polymerization leads to a disruption of cation balance. So you have an excess of intracellular calcium and a loss of potassium and water from the cell, which leads to cell deformability. Now, after these repeated cycles, the membrane becomes leaky and rigid, and they're locked in that sickle shape. Now, this differs in ability from hemoglobin A because these cells decrease in oxygen affinity, and it leads to extravascular hemolysis, where the red cell survival really depends on the intracellular concentration within the cell and the degree of membrane damage. So the lifespan can decrease to as little as 14 days. The first clinical symptoms in sickle cell anemia appear at about 6 months of age. Now, this is where hemoglobin S will predominate over hemoglobin F concentration. And these clinical manifestations occur due to the chronic hemolysis that's happening, as well as the vasoocclusion of the microvasculature. These infants will also get overwhelming infections, and the spleen will begin to enlarge because they are sequestering all these abnormal cells. The anemia can be moderate to severe and chronic, leading to gallstones, extravascular hemolysis, and possible folate deficiency. The bone marrow is hyperplastic, so it's trying to produce those normal cells, but again, over time, it can lead to an aplastic crisis and not be able to produce any normal cells, which is very detrimental. Now, vasoocclusive crisis is when those poorly deformable hemoglobin S cells have difficulty squeezing through small capillaries. The red cells behind them become blocked, giving up oxygen to those hypotoxic tissues. They deoxygenate, polymerize, and sickle, which increases that blocked region and leads to tissue necrosis. Recurrent episodes leads to infarct of tissues in the liver, bone, lung, and spleen. And again, splenomegaly in early childhood can definitely occur. You have painful swelling of the hands and feet that occur when these blockages happen. And the slow blood flow can lead to stroke, thrombosis, blindness, and even chronic leg ulcers. As for bacterial infections, the common cause of death in young patients is septicemia, pneumonia, meningitis, but certain vaccines can help protect those infants or young children from infection. Now, for the CBC, you might start to see a normocytic, normochromic type of anemia with marked reticulocytosis. The hemoglobin can be from 6 to 10 grams per deciliter, with as low as a hematocrit of 18 to 30%. Now here in the peripheral smear, you're seeing a variable amount of anisocytosis. You might see those polychromatophilic macrocytes, and what's very clinically significant is you're going to see those sickle cells and target cells. You may even see nucleated red blood cells and an increase in your RDW, which will also lead to basophilic stippling, Howell jollies, and siderocytes over time. So in addition to hemoglobin electrophoresis, when you see this, you will also perform a sickle solubility index, which is a screening test for sickle cell. So the image on the right shows you an actual sickle patient where you're having turbidity with the reagent compared to the normal patient next to it where you can see the lines through the reagent. As for hemoglobin electrophoresis, you're using a cellulose acetate at a pH of 8.4. And in this case of hemoglobin S, you're seeing that the majority of the hemoglobin in the patient below has 80 to 95% of hemoglobin S and about 5 to 20% of hemoglobin F. Hemoglobin A2 seems to be normal, but look at the lack of hemoglobin A, which is very dangerous in cases because there's no normal hemoglobin to carry oxygen to tissues. The therapy would be long-term transfusion, in addition to certain drugs such as hydroxyurea. There has been some gene therapy and also stem cell transplantation. As for sickle cell trait, this is a heterozygous state where you have one normal inherited beta chain and one abnormal inherited beta chain. It's not as severe as sickle cell anemia, where the cells can sickle under very low oxygen tension, but you still have over 50% of that normal hemoglobin A, which really doesn't lead to any clinical symptoms, and usually the physical exam is normal. Now, the importance of diagnosing sickle cell here is that both parents have to have the sickle cell trait. So if both parents have the sickle cell trait, 1 of 4 children will have sickle cell anemia, and 2 of 4 will have the trait. As for laboratory findings, you may have a normal CBC and you may or may not have anemia. Now, it's important to note if you do see any sickle cells, you mark them as present. and that sickle cell screening test will be positive. So that will be an indication, and you will also need to order a hemoglobin electrophoresis, where here you're kind of seeing the normal patient, and you're seeing the differences between a sickle cell trait and a sickle cell anemia, where in the sickle cell trait, you're still seeing half of the hemoglobin being normal hemoglobin A, and hemoglobin S may constitute about 35 to 45% of that abnormal hemoglobin, and still having normal hemoglobin F and A2 classifications. Hemoglobin C is another very common variant and happens a lot in West African countries, as well as in the United States. Hemoglobin C has a variation. Hemoglobin C has a variation in the beta chain in the 6th position of the alpha-3 helix, and there's a substitution for lysine for glutamic acid, which decreases the hemoglobin solubility of that non-polar lysine being substituted for that polar glutamic acid. And in the peripheral smear, you may see, look at that arrow, those intracellular crystals that form within the red blood cells. The hemoglobin F may inhibit some of this crystal formalization, and it may be very hard to see sometimes. The red cells with these crystals are rigid, and they will be trapped and destroyed within the spleen, which can significantly reduce their lifespan to approximately 30 to 50 days. Now, usually there's not really many symptoms here. You could have abdominal or joint pain, or the spleen can be enlarged, and a mild to moderate type of anemia. The lab findings, you could have CBCs that are from 8 to 10 grams per deciliter, and a slight moderate increase in your reticulocyte counts. Now again, here in the blood smear, you're seeing many target cells and those rare hemoglobin C crystals. The hemoglobin electrophoresis in the acid citrate agar will show 90% of hemoglobin C and a slight increase in hemoglobin F, where hemoglobin C will migrate with hemoglobin A2 on the acetate gel at an alkaline pH. Now, hemoglobin C is where you're inheriting one normal beta chain and one structurally abnormal beta chain. Patients here are usually asymptomatic, but you may see a mild hypochromia with target cells on the peripheral smear. The hemoglobin electrophoresis may show a normal hemoglobin A of 60 to 70%, while hemoglobin C only shows 30 to 40%. Now, you can also have a combination disease with hemoglobinopathies, where you're inheriting one structurally abnormal beta chain that codes for the S protein and one abnormal beta chain that codes for the C protein. Hemoglobin here, in this case, is absent, and the percent of hemoglobin S is greater than hemoglobin C, which can be more severe than hemoglobin C disease due to the complications seen with hemoglobin S and vaso-occlusion. Although hemoglobin SC is less severe than hemoglobin S, you still may see some of those sickling cells and the formation of crystals due to the hemoglobin C. Now, the anemia is similar to the mild sickle cell anemia, and vaso-occlusive crisis can develop, especially if sickling occurs, which leads to an enlarged and prominent spleen. You'll have a mild to moderate anemia here, and on the hemoglobin electrophoresis pattern, you'll have higher concentrations of S than C, no hemoglobin A, And here on the peripheral smear, you're starting to see some abnormal shapes within the peripheral blood. You'll see boat shapes, sickle cells, rare hemoglobin C crystals, and you may even see these billiard-shaped balls where the hemoglobin is moved to one side of the cell. Hemoglobin D has very many molecular variants. It is common in certain African Americans and the Indian population, where you're seeing those variants in the location of where they were discovered. So they can be classified as hemoglobin D Punjab or hemoglobin D Los Angeles. And here, the beta chain substitution will be in the position 121, and you're seeing a position of glutamine being substituted for glutamic acid. Now with hemoglobin D, you could have a homozygous condition that leads to a mild hemolytic anemia with target cells, as seen here, with 95% of hemoglobin D coming up on the electrophoretic pattern, which also migrates with hemoglobin S. If you had a heterozygous or asymptomatic or trait, this is combined with hemoglobin and another normal or abnormal type of hemoglobin. So in this condition, another combination disorder where you're seeing the abnormal chains as being one hemoglobin D variant and one hemoglobin S variant, where you can see many target cells as well as the beginnings of those drepanocytes or sickle cells. Now, hemoglobin E is the second most common hemoglobinopathy in Southeast Asia. The trait can be as high as 50% in certain areas of Thailand. Now, this is a beta 26 complication in the B8 loci, and here you have a substitution of lysine for glutamic acid, which leads to a slightly unstable hemoglobin under oxidative stress. And it kind of presents like thalassemia, which we'll be learning in chapter 14, where you're decreasing the beta chain production due to some kind of improper mRNA processing here. So you can have a homozygous state of both abnormal conditions, which leads to mild asymptomatic microcytic hypochromic anemia. This is really the only abnormal hemoglobinopathy that leads to a microcytic hypochromic type, where you're seeing lots of target cells on the smear, decreased red cell survival. Now, hemoglobin E can be either a homozygous or heterozygous trait in inheritance, and depending on the inheritance pattern, the electrophoretic pattern will vary depending on the anemia versus the trait. Now, you can also have combination disorders with hemoglobin and thalassemias cross-combining. But here in this clinical picture, you're seeing a patient with homozygous hemoglobin E, where you're seeing microcytes in comparison to the nucleus of that lymphocyte, and again, prominent target cells. Please take a look at the most common hemoglobin variants, what happens in the peripheral blood as homozygotes versus traits, where the mutation lies, and geographically how they have been determined in the past. There can be hemoglobin variants with altered oxygen affinity, resulting in the amino acid substitution in globin chains near the heme pocket, which affects the ability for hemoglobin to carry oxygen. So we've talked about the abnormal hemoglobins in chapter 5. So please go over the methemoglobin, carboxyhemoglobin, and sulfhemoglobins that can affect the oxygen affinity, resulting in cyanosis.